So this summit, I have included discussions of all chronic viral infections, hepatitis B, hepatitis C, HIV, at least as by far the major ones. I've done this for two reasons. One, I like this stuff. And if you actually look at the Fasenmyer logo, you can see this beautiful constructed artwork. This is actually an HIV virion. Second of all, I think this is really important. The intersection of biologics and chronic viral infections has two dimensions. One, these are collectively, these infect hundreds of millions of people, so they represent comorbidities, and we'll actually talk about that tomorrow, particularly from the reference of HBV reactivation syndrome, something we all have to be tuned into, and also roles in management, and certainly in hepatitis C, B-cell targeting and extrahepatic manifestations now are, we have a lot of data. So what about HIV? This is a relatively short talk, but I think it's interesting from two perspectives. One, I still get calls with some infrequency of patients who have difficult to manage autoimmune or autoinflammatory complications of HIV, and thankfully these are few and far between. And the role of immunosuppression and the question of biologic comes up, and I'll address that first because I think it's C-level evidence, but I think we can say a few things. And then secondly, I'll end on something that I think is extraordinarily interesting. And that is the potential role of biologics as adjuncts to treat HIV disease, a disease that we have not cured, presents a lot of equivalence in terms of an IMID type of disease, as we'll talk about, and we'll kind of see where we go with this. So just to remind all of you, this disease is not going away. It is here for the rest of our professional lives, and certainly will be into the next generation of physicians as well. And while there's been great progress made, amazing progress made in managing the viral aspect, it still represents a global health problem that is formidable. Now, for those of you that have practiced in the pre-HAART era or combination antiretroviral therapy era dating back to before the late 90s, there was a time when these very remarkable autoinflammatory, rheumatic complications were well ensconced in the literature. Acute onset, explosive onset of psoriasis, kind of an undifferentiated peripheral spondy-like arthritis that could be profoundly disabling. Inflammatory myopathy of numerous phenotypes and immunopathology, very distinctive. Fortunately for our patients, and data generated by us and supported by several other groups and by people, clinical experience that is widely appreciated, that after the introduction of effective antiviral therapy, the incidence of these non-suppurative inflammatory rheumatic problems have been reduced dramatically. They have not disappeared. There are still patients who have rheumatic diseases and HIV diseases that require management, but this is few and far between. I'll just draw your attention to this just in terms of completeness at 30,000 feet, that in this era, instead of seeing patients with explosive psoriasis and inflammatory arthritis, there's kind of a new spectrum of rheumatic complications, which I just draw to your attention and provide some references are. We're in a near epidemic of avascular necrosis of bone that is probably multifactorial. The hazard ratio for developing AVN and HIV is about 40. Whether this is due to metabolic effects of our therapy, chronic inflammation, or some combination of other cofactors and drugs is not really known. We're now clearly in an era where we recognize that osteopenia travels with HIV disease. Certain of our drugs, certain of the nucleotides have been well described with this. The therapies influence this. We still lack strong guidelines on testing for this and managing it, but this is the current horizon, and patients clearly are now reaching the fracture threshold, and they do respond to anti-resorptive therapy. And then lastly, which I'll just touch on for a moment, with our effective antiviral therapy, we do see immune reconstitution syndrome. Immune reconstitution syndrome is seen not exclusively in HIV patients going on antiretrovirals, but can be seen in a variety of settings where immunosuppression has been in place, and then the foot is taken off the accelerator, and with reconstitution of the integrated immune response, we can see inflammatory sequelae. This has been well described in HIV disease, and it's virtually, the vast majority of it is in the context of patients who have had occult pathogens. People who may have had CMV, retinitis, but it's been asymptomatic. People who have harbored mycobacteria in lymph nodes, but it's been asymptomatic. It's a matter of no fireman to go to the fire. Putting people on combination antiretroviral therapy, their CD4 count may have gone from less than 50 to 500 or even 1,000. And it doesn't really even take that, but it's just emblematic of the robust immune reconstitution. And within a matter of several months, patients can develop florid retinitis, central nervous system demyelinating events, often related to pathogens, including JC virus, and lymphadenitis. So that's an ID problem, it's an HIV problem, we get that and we understand it, and we really have very little role to play there, although sometimes these syndromes can be profoundly morbid and even fatal and require immunosuppression. But there is another immune reconstitution of these non-suppurative inflammatory rheumatic problems that have been well described in the literature. And these are people who, in the wake of combination antiretroviral therapy, may develop a variety of syndromes ranging from acute polyarthritis, which we've reported, fulminant autoimmune thyroid disease leading to myxedema coma, which we've reported, acute psoriasis, acute onset of sarcoidosis, like picture. And we need to be sensitized to this, because as rheumatologists, we are called in to see patients who develop these type things, being aware that it's occurring in the wake of highly effective antiviral therapy. Lets us hold our ground a bit, because by and large this is a monophasic type of illness. Some of these patients may need therapy, but it is generally self-limiting. Interestingly, in about 20% of patients that were originally described based on systematic review of the literature, they actually had pre-existing rheumatic syndromes. And everybody can remember that patients with active HIV disease, progressive HIV disease, rarely ever had fulminant rheumatoid arthritis or lupus, but quiescent disease could be reactivated in the setting of a robust immune response. So putting that all aside, in terms of the practical aspect of the first part of this talk, there still are patients with active reactive arthritis, active psoriatic arthritis, active autoinflammatory type of presentations who require immunosuppression, yet they are on antiviral therapy. And I get these calls frequently saying, you know, can I give methotrexate, can I give prednisone, can I do this, that, or the other thing? What are the evidence that patients with HIV disease, just like patients who have hepatitis B or hepatitis C, can be treated with immunosuppressives, and particularly biologics, which is the theme of this meeting? It breaks my heart to see patients with chronic viral infections and treatable rheumatic diseases be undertreated and have abysmal quality of life because we do have data. First of all, we do solid organ transplantations routinely in these patients. And these patients tolerate antimetabolites, calcineurin-based regimens, and pulse steroids. And their outcomes of transplantations of kidney, liver are in the ballpark of comparability to patients who are not HIV infected. Secondly, we now recognize that patients with HIV who have solid organ malignancies, particularly non-Hodgkin's lymphoma, can often tolerate blistering immunosuppression in terms of combination antiretroviral therapy if they have a decent immune system to begin with, leading to clinical remission and even cures of these cancers. And then lastly, vis-a-vis the last comment here about live vaccines, we have the eminence-based recommendations that we can't give Zostavax to somebody on etanercept or Humira or this, that, or the other thing. There are ACTG protocols that have been using Zostavax in HIV-infected patients with CD4 counts down to 200 as the starting point. And not only do they give Zostavax, but a month later they give another dose of Zostavax. So it's double dose. And these studies have been going on for greater than 2 years with no discernible safety signal at their last reporting. So all in all, patients with HIV can tolerate this quite well. There have been a number of small, timid uses of TNF inhibitors in rather controlled settings in the old days, but we have talked quite a bit about Bob Wallace's use of etanercept monotherapy in patients with active pulmonary tuberculosis and HIV, showing trends to resolve chest x-rays quicker, clear sputums faster, and at least giving us a hint of a safety signal. I'll cut through everything and go to the C-level evidence. If you collect all the data on patients given TNF inhibitors with HIV disease, this is what I tell everybody that calls me. I think if we use the transplant guidelines of having CD4 counts over 200, working mano a mano with a good HIV physician who has a good control of viral infection, that TNF monotherapy to me is to be preferred versus giving prednisone, which is clearly a cofactor for avascular necrosis in this disease, and actually has a lot of drug interactions with some of the cytochrome inhibitors that we use. And I actually would prefer to do that over methotrexate monotherapy as well. So these are just, that's part one, and there's a lot of opinion here on this, but I think that this is the weight of where this goes. So the second part, this is where the story gets good. This is where the story gets really, really good. I'm so happy to see an audience here who comes in from the non-HIV perspective, with the exception of Dr. Letterman, who's sitting up here in the second row, who should be giving this talk from this point on, but I'll do my best. So what's the deal? So we are here, and this meeting, which is different from a lot of other meetings that a lot of us go to, it's really cross-disciplinary. And tomorrow afternoon, we're going to be talking about everything from multiple sclerosis to psoriasis to immune-based therapies of cancer and transplantation, and trying to share our knowledge and our ignorance at the same time. And this is all based on the concept of IMiDs. And IMiDs is a construct, and we like it. The slide at the beginning, that whatever causes these diseases causes a perturbation of this integrated immune response that brings in some kind of common players. And who would have thought when we were in training that you'd be treating rheumatoid arthritis like you treat psoriasis or Crohn's disease. But we do now, and this is the main line of IMiDs, and we appreciate this now, and we actually think of this paradigmatically. But the next wave of IMiDs is down here. And this is, like we were talking this morning in the plenary session, about the role of inflammation in many, many other diseases. Everything from type 2 diabetes and type 1 diabetes as well, with type 2 diabetes, where the data are hot. Obviously, sepsis, vasculitis. We'll focus a lot on atherosclerosis, and I've included HIV in this because HIV is an inflammatory disease. It's an infection, but it's driven by inflammation. This is an old slide which we've kind of have used for many years, but it makes the point that if you take patients with acute HIV and we look at all the markers of soluble and cellular immune activation, and these are just the old ones that were looked at, they're markedly elevated. But what is interesting to note that this is a natural history study, but even with highly effective therapies, I'll talk to you in a second, and even in people who control this disease endogenously, elite controllers or long-term non-progressors, they still have inflammation in their blood. And while people do mighty well with HIV disease, and they live a lot of years and a lot of decades, they still have accelerated aging and accelerated end organ disease. So the last little part of this talks about the background of this. So right now, patients don't die of opportunistic infections unless they don't have access to drugs, they don't take their drugs, or they're resistant to drugs. But the leading causes of death are what we call non-HIV associated events. And a lot of this is cardiovascular disease. There's still an increased rate of a variety of forms of malignancies. And a number of studies have correlated these events with inflammation. I won't talk about these trials, but some of these trials have demonstrated very, very high hazard ratios for persistent elevated inflammatory markers, in particular things like IL-6, which I'll come back to in a minute. There are other studies that have demonstrated that the presence of inflammatory markers such as IL-6, D-dimers, monocyte activation markers correlate very strongly and independently with these bad outcomes. So I'll show you two pieces of data and then end with a concept. So this is a study we call it the CLIF project. This is led by, Dr. Michael Lederman, done in conjunction with collaborating physicians throughout the greater Cleveland area. And we collected patients who were immunologically failing. To define this means that people who had excellent control of their virus, non-detectable control of their virus, but unlike their more successful counterparts or controls, had failed to regenerate their immunologic battery. The marker that we used was about 350 cells. It can be defined in a variety of ways. Why does one person go back up to 1,000? Why does the other person not make it? So failure to normalize these CD4 cells. And then we, in a case control type of fashion, asked what are the determinants of failing to recharge your immunologic battery. And this is not uncommon. Maybe as many as a quarter or a third of patients do this. So this is important. So there are tons of data from this study that have been published, but I just use this as a representative study of looking at cell-associated activation markers, expression of HLA-DR and CD38, both on CD4 and CD8. These are the immunologic failure patients. These are people with HIV disease who are virologically controlled like them, but they've recharged their battery, and these are healthy controls. And whether you look at this, whether you look at soluble markers, look at some determinants of cell cycling, there was evidence that failing to recharge immunologically is related to ongoing and persistent inflammation. An interesting notion. This study, another study from the same group, Benigno Rodriguez and Michael Lederman and a ACTG group of co-authors, presented this at the recent retroviral meeting, and I think this is just an amazing study. So it looks at the relationship of inflammation and immune activation on these non-HIV related events. So within the ACTG, there's a cohort known as ALERT. This is culled from many, many different clinical trials. These patients are meticulously followed with clinical data and biobanked. And from this, they could draw on patients over a defined period of time who experience non-accidental death of any sort, and these incident non-AIDS-related morbidities, including myocardial infarction, stroke, and malignancy. I'm just focusing on these. Then they could match them with controls who came into the study with the same CD4 count, same age, race, sex, well matched, and then look for determinants, if there were any, to be found of what caused these outcomes. Now, like the previous Cliff study, I could show you many, many other studies, and they looked at markers at baseline, they looked at markers at 1 year, they looked at markers immediately prior to the event, and at the end of the day, these are our molecules that we've been talking about all day. Here you have soluble TNF receptors, you have IP-10, you have IL-6. Looking at this as the highest hazard ratio for death after adjustment. In all of these studies, even a single determinant coming into this study of an elevated IL-6 was independently associated with these severe outcomes. So that's an interesting study. It's an interesting bit of data. What does it mean, and what can be done about it? I put this together here in the last few weeks because we're very interested in telling the story. Here we have 3 diseases: atherosclerosis, rheumatoid arthritis, and HIV. I believe that there are strong data to say that HIV and rheumatoid arthritis share the same signature as a risk factor for accelerated cardiovascular disease. And this can be taken from monocytes, markers, soluble markers, cell-bound markers. It is a very interesting seam between diseases. So now moving on to the final aspect. So say this is a big deal. So if persistent immune activation is making a case, being a correlate of these severe outcomes, what can be done about it? Well, I've had the pleasure to come to the ACTG on several times and talk about all the tools in our toolbox that we have, and there's been a lot of interest. And you can parse through these many different ways, but I want to kind of close by talking about IL-6. And I think that this slide has already been shown. I don't know if I got this from Artie or he got it from me or whatever. This is IL-6, highly pleiotropic cytokine, immune and non-immune origin with hematologic and non-hematologic targets. Has a lot to do with a lot of things. Now, if we had a lot of time, I'd ask Dr. Letterman to come up and tell this story, but I'll try to condense it to 3 sentences or less. There is evidence that IL-6 is a driving force of this immunologic failure. IL-6 likely comes from the bowel. IL-6 is a driving force that inhibits the replacement of CD4 cells by some sophisticated mechanisms of downregulating their ability to respond to growth factors, and probably creates a vicious cycle within the bowel where microbial translocation is the driving force for IL-6. This is a very hot story in HIV disease right now, but it's a theory. Is this an association, or is this actually pathophysiologically linked? So recently, we have had an approval trying to work its way through some of the regulatory aspects, again, led by Dr. Letterman, that in a multi-center fashion, we will be studying the effects of IL-6 blockade in patients with HIV disease who fall into that type of category of immunologic failure. We'll be giving tocilizumab in graded doses. Obviously, this is monotherapy. There's no methotrexate. There's no prednisone. Start at 4, try to go to 8. And there are basically 3 specific aims. One is try to actually tease out, and using this as a tool to tell us whether IL-6 inhibition is actually centrally involved in the pathogenesis of immune failure and this inflammation. Secondly, we're going to take advantage and take a very deep dive on the effects of IL-6 inhibition in HIV as a cardiovascular risk equivalent by looking at a variety of surrogates and markers of accelerated cardiovascular disease. And then certainly today, now I feel totally imbued by this morning of omics that I'm trying to get smarter to understand the relationship between the transcriptome and the metabolome and the microbiome, but all the omes will be studied in this study in a very detailed fashion. So that is my story of HIV and biologics. I think that this is just a perfect example of where 2 disciplines can look at a seam that, to either side may be less clear than when it's looked at jointly. So, thank you.